Good morning, everybody. Good morning. Good morning. Very good morning to all of you. We'll just wait for 5 minutes to let everybody join in and then we'll start. Okay. Good morning. Good morning. So, are we ready to start? Had breakfast, everybody? Fresh mind? Okay, so let's start. Okay. So, welcome to OMR live classes. All right. Before starting with the class, I would like to share some important points that we are going to follow for next 10 days. Okay. Not just for 10 days, you can follow it throughout your preparation or for other subjects also. All right. So, the OMR live sessions that we are going to take, they are about understanding the concepts. Okay. And applying those concepts to solve your questions. Okay. We'll be working on PYQs. We'll be working on PYQs. Okay. Why PYQs? Because they form backbone for your preparation. Remember, 60 to 70% of questions that are asked in your competitive exams are either repeat or twisted questions. Okay, or either based on same topic. Okay, so revising the PYQ again and again will give you a real edge. Okay, so we will follow these tips. We'll try to follow. Okay, first you will have to focus on the class. Okay, sit with full focus. When you learn in the class, okay, when you concentrate in the class and then you revise that or revise the same content within 24 hours. That becomes your first revision. You will remember it very nicely. Okay. So, third point is solve QBs, PYQs based on discussed topics. Okay. Solve QBs, PYQs based on discussed topics. Fourth, give all the GTs, SWTs, and PCTs. The more questions you solve, the more your doubts get cleared, your concepts get clear. Okay. So try to solve as many questions as possible. Next point is note down every mistake you do. Note down every mistake, meaning what? When you are solving your questions, in some questions you will find it difficult to solve. Okay, it's difficult to apply concepts. So you will make a notebook or separate, you can say notes where you will write down your mistakes. Okay, and that will be your personal guide to what needs revision at the end of your preparation. So those topic you will have to focus more on. Okay, so fifth point is this. Sixth point is keep a track on keep a track on recurring PYQs. Okay, recurring PYQs that becomes your high yield areas. Meaning what? The topic based on which PYQ is asked, you can just write down those recurring PYQs and then you will focus more on those topics. Okay, so these are some tips that we are going to follow. And let's start with the oral medicine. First topic of oral medicine, that is primary and secondary lesions. Okay, primary and secondary lesions. And before that, I'll give you some important topics. Okay, I have curated these topics based on your PYQs. So, first important topic, syndromes. Okay, many a times or syndrome based questions asked frequently. Okay, every exams you will find two or three syndrome based questions, so you will have to be thorough with all the syndromes. Clinical features, okay, triads, and some image based questions. Okay, you will have to be thorough with those. Second topic is red and white lesions. Red and white lesions. Okay, topics or questions based on this have been asked. Third topic is viral infections. Third topic is viral infections. Okay. Fourth topic is oral pigmented lesions. Oral pigmented lesions. Fifth topic is salivary gland. Most of the questions were from salivary gland diseases. Okay. Make it very, very important topic. Sixth topic is orofacial pain, the neuralgia based question. Okay, neuralgia based questions. So these are some, yes, questions have been asked from other topics also, but these are very important. Okay, frequently asked questions. Uh, okay, so let us start with the, this is our index. You must be having this index, correct? First topic that we are going to start with, primary and secondary lesions. Primary and secondary lesions. Okay. Now, what are these primary and secondary lesions? Before starting with any of the topic in oral medicine, you should know this basic primary and secondary lesions. Based on this, we are going to diagnose, we are going to give a differential diagnosis of variety of conditions. Okay. So why this is important? What is primary lesion is, it is basically initial initial change, okay, that occurs in disease process. Okay, primary lesion is what? The initial change, the fundamental change that occur in disease process. Okay, and it is first manifested clinically. It is first manifested clinically. Initial change in the epithelium that is manifested first. Okay, what is secondary lesion? Secondary lesion is, as disease progresses, what happens is, due to trauma, due to infection, due to scratching, rupture, or healing. Okay, due to all of these factors, the primary lesion undergoes structural modification. It undergoes structural modification. Okay, that is called as secondary lesions. So, in easy language, what is secondary lesion? It is just altered primary lesion. Altered primary lesion. Okay. So, primary and secondary lesion. We have a list of primary lesions and secondary lesions that we are going to discuss now. What is importance of this primary and secondary lesion? What is importance of it? First importance is, it is used, or we can recognize the disease pattern. Recognize a disease pattern. Meaning, if you notice some primary lesion clinically, okay, you will immediately understand what might be the diagnosis of it. Okay, but the same primary lesions is shared by variety of conditions. Okay, so again, this is useful for differentiating similar conditions. Okay, you will understand it better when we move further. Okay, it is used for differentiating similar condition, means two disease or two conditions shares similar primary or secondary lesion. Okay, so recognizing those will give you an edge, and you will be able to differentiate those conditions, not just by recognizing primary or secondary lesions. You will have to take a history, you will have to investigate, you will have to carry out some tests, and then you will reach to the final diagnosis. Third one is, you can also identify the stage of progression of disease. Meaning what? If I take an example of ulcer, aphthous ulcer, correct? Aphthous ulcer. The primary lesion of aphthous ulcer is papule, okay? And the secondary lesion, the last lesion that we have is a crust, okay? So, disease progression, meaning conversion from papule to crust, okay? That is disease progression. This is the last lesion that we see, correct? So, uh, I'm sorry. I was going to take an example of herpes labialis, not aphthous ulcer. I'm so sorry. Okay, herpes labialis. Okay, so herpes labialis में the primary lesion is vesicle, and then it converts, and the secondary lesion, the last lesion in herpes labialis is a crust. Okay, so the disease progression you will get to understand by learning about primary lesion and the secondary lesion. Okay, so let's start with the first primary lesion that we have. Okay, so first primary lesion that we have is a vesicle. Okay, what is vesicle? Can you appreciate this? Can you appreciate this and this? Okay, these are fluid filled blisters. Fluid filled blisters, correct? And the fluid is serous fluid. Serous fluid filled blister. What is difference between this vesicle and bulla? Both are same, just a size difference. Vesicle is less than 1 centimeter in diameter and bulla is greater than 1 centimeter in diameter. Okay, and we are learning about primary lesions first. Okay, so primary lesions, these are manifested first. Okay, you will see clinically uh, vesicle, bulla as a serous fluid filled blister. Just the size difference between both. Vesicle is less than 1 centimeter, bulla is greater than 1 centimeter, and you will see vesicle. The example of disease or the condition in vesicle is herpes zoster. Okay, example of condition in which you will see bulla is pemphigoid. Pemphigoid may you will see bullous lesions. Okay, so these are first two primary lesions. Second, third primary lesion that we have is papule. Okay, papule, as you can see in this picture, it is a raised solid lesions. It is not fluid filled or anything like that. It is raised solid flat lesion which is less than 1 centimeter in size. Okay, so basically these are mix of variety of lesions, but the lesion which is less than 1 centimeter in size is our papule. So papule is raised solid flat lesion. Okay, and the condition in which you will see this papule is focal epithelial hyperplasia. All of these condition we are going to discuss it, okay, later. Just In which condition you will see all of these lesions? That's why I'm writing it down. Okay. Okay. This this is what? This is discolor, discolored mucosa. Okay. This is discolored mucosa. So discoloration of mucosa is called as macule. Macule. Okay. Macule is discoloration of mucosa, and this macule we are going to study it in pigmentation chapter. This is also a primary lesion. Okay. This macule is due to increased melanin synthesis. This macule is due to increased melanin synthesis. Okay. Next primary lesion that we have is the plaque. Plaque, as you can see here, plaque is raised white lesion. Okay, raised white lesion, and this is greater than 1 centimeter. It is greater than 1 centimeter. Okay, this patch is greater than 1 centimeter. Difference between papule and the plaque. Plaque is greater than 1 centimeter in size. It is raised white patch, whereas papule was raised solid lesions, which is less than 1 centimeter in size. Okay. This plaque, you will see it in this condition, which is leukoplakia. Leukoplakia. Okay. Moving on to next primary lesion, which is pustule. Pustule. As the name suggests, pustule. So, it contains purulent pus. It contains purulent pus containing blister. Containing blister. Okay. Pustule. What is different between vesicle and the pustule? Pustule contains purulent pus, whereas vesicle contains serous fluid. Okay, serous fluid. This pustule, you will see it in chicken pox. Chicken pox. All right. Okay. Moving on to the next primary lesion. What is this lesion? This is a nodule. Nodule is dome shaped, dome shaped. It protrudes above mucosa. Okay, can you see? It is dome shaped and protrude above mucosa. This is seen in fibroma. This is seen in fibroma. All right. Okay. So these are some primary lesions that we need to learn and we need to remember. Okay. Moving on to secondary lesions. Moving on to secondary lesions. First secondary lesion. Secondary meaning altered primary lesion. Altered primary lesion. So you see vesicle clinically. You will see first manifest vesicle, then you have vesicle will rupture and forms ulcer. Ulcer becomes your secondary lesion. Okay. So secondary lesions mein first we have is the erosion. What is erosion? Erosion is thinning. Erosion is caused due to thinning or atrophy of epithelium. Okay. And erosion, you will see it here you will see it as a moist skin. Okay, the epithelium is thinned over this area, okay, or atrophy has happened, and you will see it in the condition called as erosive lichen planus. Erosive lichen planus. Okay, can you see this thinning and the white mucosa with surrounding erythematous border? With surrounding erythematous border. Okay, this is erosion. Second one is this. What is this? This is ulcer. This is ulcer. Ulcer is just a epithelial defect, or you can say discontinuity in the epithelium. Epithelial defect. Okay, this is epithelial defect, and this defect is covered by fibrin membrane. At the center, you will see fibrin membrane. This will have yellow to white appearance. Yellow to white appearance. Okay, this is ulcer. Next secondary lesion that we have is this. What is this? This is scales. Okay, scales meaning the flecks of cornified layer. Flecks of cornified layer. Cornified layer means the superficial most layer of the epithelium. So flecks of cornified layer. This scales, you see it in the psoriasis. Psoriasis is a dermatologic disorder, and you will see the scales in those. Okay. Next secondary lesion is crust. Crust that I was talking about in herpes labialis. Correct? Crust is a dried exudate of skin. And this is a last stage of herpes labialis. Okay, last stage of herpes labialis. So I was telling you disease progression. You will understand the disease progression. This meaning the disease is healing. Okay, this stage meaning your disease is healing, or your lesion is healing. Okay, this we already know, this is herpes labialis. Okay, next is the easy one, is scar. Scar is just a excess collagen production after injury. After injury, okay, or after surgical healing also you will see this scar. Correct? So this is scar. All right. So this was the last secondary lesions. I hope you understood all the primary and secondary lesions. Okay. You guys can type it in the chat box, whatever doubts you have, and if you understood the topic or not. Clear with primary and secondary lesions so that we can move further. Now that you understood about primary and secondary lesions, from topic of red and white lesion, you will have a mention of primary and secondary lesions. Okay, so that time you will understand the importance of this topic. Okay, yes, okay. Just a minute. Okay. Uh, Erosion. Okay, erosion, I'll explain it again, then we'll move further. Okay. So erosion is what? Erosion is just a thinning. Okay. It's just a superficial defect. It does not penetrate into basement membrane. So it's just a superficial layer getting thinned. Okay. And the skin will be moist. When there is a erosion, your skin will be moist here. Okay. And you will feel or you will see it as a red surface. Okay, red, raw and smooth surface. In ulcer, what is there is in the center we have formation of fibrin membrane which gives it yellow to white appearance. Erosion में ऐसा नहीं रहेगा. Erosion is just a red surface, red moist surface, and patient will have a pain. Okay, often patient experiences pain. All right. Okay, chalo. Let's move on to the next. So, let me tell you guys, I am going to provide PDF for this every class after the class. Okay. So, if you miss anything, don't worry, I'll be providing that. And if you have got notes, okay, I have added some extra points or extra topics, okay, which are not there in the notes. So don't worry, I'll be providing the PDF, and uh, you can just hear or learn whatever I am telling you. PDF के बारे में और for writing content, don't worry about it. Okay, चलो. Then we have first topic of the day, which is red and white lesions. Okay, red and white lesions. Okay, now okay, there are some doubts I can see. Secondary lesion names, I'll provide you PDF. Sahin, then Harshit, Petike, Petike, ecchymosis, everything comes under primary lesion. Okay, all right. Chalo, red and white lesions. Now, why the name red and white lesion here? Okay. Now, oral mucosa, if you see the normal color of oral mucosa is translucent pink. Okay, but oral mucosa is exposed to variety of factors like trauma, like microbes, like chemicals, like allergens, or any systemic conditions manifest, um, you can say, oral manifest as a oral lesions. Correct? So systemic influences also um, uh, affect oral mucosa. Okay. As a result, it exhibits variety of color. As a result, it exhibits variety of colors. So trauma, microbes, chemicals, allergens, okay, systemic influences. This is responsible for color change, mucosal color change. Okay, and the most common color that you get to see is red and white color. Red and white color. Okay, so This color alteration, so why the mucosa becomes white, why the mucosa becomes red, it all depends on the underlying changes. The underlying changes concept, what are the underlying changes? Changes in the epithelium, connective tissue, changes in the vascularity. Okay, so these factors are responsible for color change. Okay, and the range can vary from the, it can give rise to either variation harmless variation of mucosa to potentially malignant disorders. Okay, these changes can bring harmless variation or harmless changes to the mucosa to potentially malignant disorders. Okay, this is the reason why we are studying red and white lesions. All right, so what are the changes that you get to see? What are the underlying changes? Normal color, normal color of mucosa is translucent pink, correct? Now, when the mucosa, the color becomes white, that means what is happening? First change, that is thickness of epithelium. Thickness of epithelium. Okay, thickness increases, changes to white color. Second, amount of vascularity. Amount of vascularity. Now, if vascularity decreases, that can cause one condition. Okay, I'll tell you the conditions also. Third, degree of keratinization. Degree of keratinization. Degree of keratinization means when there is excessive keratin production, excessive keratinization, that leads to one condition. Fourth one, formation of pseudomembrane. Formation of pseudomembrane. The thin layer that forms over the epithelium or mucosa, it is pseudomembrane. Fifth, due to pigmentation. Due to any pigmentation, the color changes. Okay, so thickness of epithelium, that means when the epithelium thickens, we have one condition called as leukoedema. We will be discussing this. Amount of vascularity, when vascularity decreases due to any factor like excessive collagen production, that leads to OSMF. Okay, degree of keratinization, when degree of keratinization increases, it leads to one of the condition is leukoplakia. Formation of pseudomembrane. Pseudomembrane seen in candidiasis. Okay, and pigmentation, we have a macule that we studied under primary lesions. Okay, so this is how these are some factors that can lead to the white color of mucosa. Okay, now what we are going to do, we are going to study all these conditions under the headings. First heading is normal variation. Normal variation of oral mucosa. Second heading is post-inflammatory. Post-inflammatory lesions. Okay. Then PMDs. PMDs is potentially malignant disorder. Please remember, potentially malignant disorders. Okay. Now, important point for PMD is important point for PMD is Earlier, PMD was termed as pre-malignant lesions and pre-malignant conditions. Okay, but in 2005, WHO has renamed these two, or merged these two terms into potentially malignant disorders. This was one of the PYQ. So please remember, very important. Okay. Earlier, we used to study premalignant lesions and conditions separately. But 2005 में WHO has merged these two terms and made it into PMD, potentially malignant disorders. Okay. The last one is the white lesions, last group of lesions with no malignant potential. No malignant potential. Okay, so we will be studying the diseases or conditions in these groups. Starting with the first group, that is, okay, I'll just show you the table that we used to learn earlier. Okay, this is the table. We used to study premalignant lesions separately, okay, and premalignant conditions separately. Okay, but now we are just going to study this together. And the most important condition that we are going to study are leukoplakia, lichen planus, lichenoid reactions, erythroplakia, systemic lupus erythematosus, and OSMF. And OSMF. The most important lesions and questions based on this lesions have been asked. Okay, so let's start with the first group of uh, lesions, that is normal variation of oral mucosa. Normal variation. Okay. Before that, I'll just show you. Okay. I'll show you this table later. Okay. So first lesion or first normal variation. What do you mean by normal variation? It's just a normal mucosa. It is not any disease, not any condition, normal variation of oral mucosa. Some people, some patient will have this findings. Okay, many of you, most of you will have this finding, or we are going to study three conditions in normal variation. So you people, most of you guys will have this lesions or normal variations. Okay, first normal variation is leukoedema. Leukoedema. Okay, can you see this appearance? This is grayish, white, translucent lesion, correct? Translucent lesion, grayish white translucent lesion, and it has got folded or wrinkled appearance. Folded or wrinkled appearance. Can you see these folds? Correct. Now, what is this? What is the speciality or important point to remember about this? You can write it down or make it as an important point. It disappears on stretching. It disappears on stretching. This is very important point. You can get MCQ based on this. Leukoedema. Can you see the wrinkled appearance? When you stretch that mucosa, the lesion disappears. Okay. What is histopathology behind this lesion? What is histopathology? What happens here is there is a abnormal thickening Abnormal thickening of spinous layer. Spinous layer. Abnormal thickening of spinous layer is called as acanthosis. Acanthosis. Please remember the term acanthosis. Okay. And there is intracellular edema. Intracellular edema. When you stretch it, the fluid settles down and the lesion disappears. Okay. The spinous cells, spinous layer. Can you guys remember the layers of epithelium? Spine, a corneum layer, granulosum layer, spinous layer. Then we have basal layer. Okay, so spinous layer shows abnormal thickening. Okay, and it has got intracellular edema due to fluid accumulation. So when you stretch it, the fluid settles down and the lesion disappears. This is histopath behind leukoedema. Okay, this is first normal variation that we have. Next normal variation that we have is Fordyce's granules. Fordyce's granules. What are Fordyce's granules? Can you guys see this yellowish to white spots? Small, small yellowish to white spots. Yellowish to white spots. You can easily see it in most of the patient. You will find this Fordyce's granules. What are these? These are ectopic sebaceous glands. So sebaceous glands is not supposed to be here in the mouth, but it has got ectopic they are ectopic sebaceous glands. So you will see it on the buccal mucosa. Correct? Hmm. No signs or symptoms. Patient doesn't know only when you see it clearly, when you examine the mouth or oral cavity, you will notice this Fordyce's granules. Okay. No treatment is needed. No treatment is needed. Okay. These normal variation, no treatment is needed. Okay. They are just present. It has zero malignant potential. They are just a variation. Normal mucosa, they are just a variation. Okay. Moving on to next normal variation, which is linea alba. This is also most commonly seen. Linea alba. What is linea alba? Can you see this white keratotic line? White keratotic line, which is parallel to your occlusal plane. This is white keratotic line parallel to occlusal plane. Okay, this white keratotic line is due to continuous friction. Okay, when you close your mouth, okay, the maxillary and mandibular teeth, when they close, the cusps or the surfaces of teeth, okay, causes friction on the mucosa, and that can lead to this white keratotic line. Increased friction will the mucosa will have its defense mechanism, and defense mechanism is increased production of keratin. So white keratotic line is seen parallel to the occlusal plane. Okay, so this is linea alba. This is also most commonly found. So this is the third normal variation that we have. Okay, now next group of lesions, post-inflammatory. Post-inflammatory group of lesions. First is traumatic keratosis or frictional keratosis. frictional keratosis. Okay, so traumatic keratosis, frictional keratosis causes due to source of irritation, source of irritation. In most of the patient, you will notice the wisdom tooth, the mucosa adjacent to wisdom tooth, and the wisdom tooth which is not normally erupted, which is slightly buccal, slightly you can say tilted, okay, and it is causing continuous friction to the mucosa. There you will find this traumatic keratosis or frictional keratosis. Okay, the most common sources of irritation for it is sharp teeth, okay, or rough flange of denture. Denture patient maybe you will notice this kind of lesion. Okay, this is when you notice areas of friction, there is an increased keratin production by mucosa, and that can lead to this keratosis. Okay, so this is the first, you can say, post-inflammatory lesion, and this is due to mechanical or physical trauma. Physical trauma. Okay. Second lesion is this. What is this? This is cheek biting. Many patients have this habit of cheek biting or lip biting. Correct? Now, cheek biting की वजह से what happens is this this is the lesion that you can see. This is poorly outlined, loosely attached, loosely attached epithelium, loosely attached epithelium. Okay, due to continuous cheek biting, this condition happens. Okay, and the other name for cheek biting is morsicacio bacorum. Morsicacio bacorum is the other name for cheek biting. And when you notice such lesion, you can ask history to the patient or ask habit history. Okay, so he'll give you habit history. He has got habit of cheek biting like this. Okay, so you will see this lesion, and there will be a loosely attached epithelial, you can say, areas. All right, this is second lesion due to mechanical trauma to the mucosa. Next next lesion is a thermal cause. Thermal burn, you will say. Thermal burn is caused due to hot food, hot beverages, okay, hot food such as pizza. Okay, the hot pizza can give you this mark. Okay, so this is the thermal burn. When you have hot food, beverages, hot coffee, tea, you can get this lesion, or this lesion can be iatrogenic, meaning what? Dentist can cause this lesion. How? Because we handle hot instruments, correct? We handle hot instruments. So unintentionally, what happens during working, there can be unintentional uh, contact with the mucosa. Unintentional contact of hot instruments with the mucosa. That can lead to this thermal burn. All right. So hot instruments, where do we use hot instruments? Simple example, for obturation, for condensation of GP material, correct? So it can be iatrogenic. This is the second lesion, post-inflammatory lesion. Third post-inflammatory lesion that we have is chemical burn. Now, name itself suggests chemical burn, contact with the contact with the any chemical, contact with chemical can give this lesion. Okay. Now, sometimes what patients do, aspirin, tablet aspirin, or oral bisphosphonate, correct? What they do is, instead of taking it with water, they keep it just adjacent to the tooth that is paining. Okay, I'm talking about aspirin only, but some patients uses this oral bisphosphonates also. So what happens is, this continuous contact with the chemical or the drug or the aspirin can give this chemical burn. Can you see this? Can you see this pseudomembrane formation? This is due to aspirin. This is called as aspirin burn. When it caused due to aspirin, it is also called as aspirin burn. Okay, I'm just giving you example. Patient does these things. Okay, they keep or they will apply clove oil. They will also apply clove oil for tooth pain. Okay, and the adjacent in the adjacent mucosa that can give us chemical burn. Chemical burn mein what happens is pseudomembrane formation. This is a pseudomembrane formation. So what questions can be expected from this topic? So you will have a question where they ask you, patient has used this chemical and then it developed pseudomembrane formation or the lesion, or they will give you picture, and then you will have to diagnose which lesion or which is the diagnosis. What is the diagnosis? And they will give you in the option chemical burn, thermal burn, and other confusing options. So when you have a um, history of chemical use, okay, and they will give you this picture, then you will mark this chemical burn as your diagnosis. Okay, so yeah, this is the last post-inflammatory lesion that we have. Okay, now what we will do is we'll continue this. Okay, till now, any doubts, any queries, then we can solve it and we can take a break. Any doubts, any queries? Any doubts, any queries? Then we can take a break and we'll continue with the second session in the app. Okay. So I think any treatment for leukodema? No, no dear, no treatment. I told you normal variation के लिए there is no treatment needed unless for fordyces granules. If patient is concerned, aesthetic has got aesthetic concern, then he can undergo laser treatment for fordyces granules. But otherwise, no treatment is needed for leukoedema. Okay. Yes, chemical burn may you have a formation of pseudomembrane. Pseudomembrane. Okay. We discussed about reasons of white lesions, correct? So formation of pseudomembrane was one of them. So chemical burn may we have a formation of pseudomembrane. Divya, Aditi, and who is this? SSJ. Clear, everybody? Clear, everybody? Chemical burn का treatment, you will have to stop using that chemical first of all. Okay. Or and you will have to give conservative treatment, so symptomatic treatment. If patient have pain and everything, you can give topical lignocaine gel, okay, for pain relief, and then it will get fine within 2 or 3 days. Okay. Priyan Kaushik. Okay, chalo. Red lesion, causes of red lesion, first and foremost, thinning of epithelium and atrophy of epithelium. This is the most important cause of red lesion. Thinning and atrophy of red lesion. Infectious bhi hota hai, but most important is thinning and the atrophy. Traumatic keratosis associated only with third molar? No. One of the example of traumatic keratosis is due to third molar. Okay. It can cause due to sharp tooth. It can cause due to the rough surface of denture, flange. Okay. What is the name? Sumaya and Abdullah. Okay. No, no. Linea alba can develop over the years. Over the years, when there is a eruption of permanent teeth. Okay. And the continuous friction with that can form the linea alba. It is not present since birth. Yes, linea alba is also present due to friction. All right. I hope I have cleared doubts, and we can take a break. Take a break for five minutes, and then we'll continue on the app. Okay. Chalo. Bye bye.